Welcome, everyone. I want to thank you all for coming. What I want to talk about today is a bunch of things, but first I want to thank the people who make this possible. The Viva Learning people, Colteen, who was the sponsor of this webinar, but most of all, you for showing up and giving me your time. And I hope it's valuable for you and you gain some insight. What are we going to be discussing? Well, we're going to be discussing what is modern adhesive restorative dentistry. I want to talk about prep design. I want to talk about scanners and analog, touch on some printing, tissue management, adhesion, and then how to properly treat these restorations. It seems like there's a lot of confusion, but it's actually pretty straightforward. And hopefully you'll see that in some of the diagrams I'm going to show. And then at the end, we'll have a Q&A. So to me, what is modern adhesive restorative dentistry? I've been doing adhesive dentistry for 35 years. I started with the first adhesive that was ever released, dentinal adhesive, which was all bond back in 1990. So that is pretty much what I've clung to my whole career, because to me, it was a way to conservatively prepare teeth, and I could bond stuff to the teeth instead of grinding everything down through a crown. So to me, this was it. But to do this, I think you have to have a proactive approach. You really have to think through the whole process. And this is just dentistry in general, but a proactive approach to the profession is really a good one because you have less stress, less time to do, and more predictable, and you have happier patients, less redos, definitely. So in proactive planning, a case like this I did, this is a woman who comes to you and says, well, I want a nice smile. Well, yeah, that's easily said, not easily done, because obviously we have issues. So what do you do with this person? Do you do ortho? Do you do just opening? You have to do a full exam, find out their history. And someone said once, I remember hearing 30 years ago, someone said, if you look in someone's mouth, they will tell you their history. I mean, if you look at this person, there are numerous things. First of all, if you look at her vertical, the top of the cervical, of the uppers and the lowers. I mean, this is probably no more than 10, 11, 12 millimeters. If you look at the bottom, look at this. The curve of Spee we know is anterior to posterior. Curve of Wilson, she has an opposite curve of Wilson. Look at this. Those lingual cusps are higher than the buccal. So we have some real issues here. You can even see it here. Look on the right side. Lingual cusp higher than the buccal. So you have to truly address this. And I always tell people what you have to do is you have to put them in trial teeth before you finally restore, which is exactly what we did. And these are her final restorations. And look at the amount of vertical opening we did from here to now here. And this was all done, this actual case took approximately a year to do, approximately a year. Some cases I've done a little shorter, but some longer. It really all depends on what the patient can tolerate and what they present with. So if you have someone coming in like this, and this is the reclusion, especially because if you look at the bicuspids, there's hardly any wear, maybe a little bit, on the lingual cusp of one of the bicuspids you can see right about here. But look at this. Look at how they've trashed the distal of their molars. This is very indicative of certain occlusal trauma and the issues they have. You can't just put crowns on these teeth. You can't just grind them down and put onlays or whatever you want to do. They're going to fail because their own tooth structure is failing. Nature is failing. So you have to figure out what's wrong before you get in there. So one of the best proactive tools we have nowadays is this. It's the digital scanner. Now, I've had digital scanners in my office for over 20 years. I have multiple digital scanners. Some are hooked up to in-office CAD/CAM and some are alone. But this is, to me, one of the best tools you're ever going to have, because it's not only a good thing for impressions and other things, it's a teaching tool. Okay. You can show, especially a lot of the software. Now I have the Medit scanner in the system, but I can show the patient their guidance. I can show them excursive movements. I can show them their protrusive. They can see why they're wearing and tearing the teeth the way they are, because they have to have buy-in. Buy-in will get them to do work. So I always scan a new patient and we show them the potential problems and cracks. This has to be replaced. We show them where that they're not aware of. And then we can show their lowers. The great thing is this is a great tool to show their bad hygiene. Oh, I floss every day. Really? We have all heard that. It's funny, but if you show them that, I go, well, you're missing a big area. Documentation is great. But how many of us have digital scanners? And before I say this, I'm a firm believer that you don't need this stuff to be a great dentist, because I have a dentist in my complex and he's around my age. I'm 61 and he doesn't have any of this stuff, but he is a really, really good dentist. I would let him work in my mouth any day of the week, but he just doesn't need it. He feels he doesn't need it. Now, I think there could be some benefits for him if he bites into it, but he's just not. But he's an amazing dentist. So these are tools. Understand they're just tools. So how many of us have digital scanners? According to this survey, a little over half. I guarantee right now it's probably more for sure. Okay, it's north of 53% for sure. But how much, I don't know, but it's a little more north. But you have to understand the difference between scanning and taking an impression. And one of the big differences people don't realize is that impression material has physical attributes to it. It can help displace tissue. And if it can help displace tissue, that can enable you to see the margins, versus with a scanner, what you see is what you get. And I think you have to be better with tissue management with a scanner versus an impression. So the people that just jump to scanners and say, I don't use impression material anymore, I just scan. Well, to me, they're running before they're walking. And they really have to get their techniques down before they go into scanning. Otherwise, if you talk to any local lab, they'll tell you what they see, and this is what they get. When you get stuff like this, where's the margin? It's a guess, okay? Versus something like this, which is readily identifiable. This is proper tissue retraction. This is proper scanning protocol. But this is what the lab really needs, but they rarely get. Just talk to your lab. One of the big problems is we have to realize materials have changed. So we typically have two types of margins. We have the feather, I always called it the infinite bevel, or the chamfer. Now, if you look at them from a profile, the chamfer margin and the resulting crown, you have a nice emergence out of the tissue onto the tooth. With a feather margin, you think you have it, but you don't, because this is essentially what you're getting back. And that is what? It's a food trap, okay? It's a food trap. You have tissue gingival inflammation, right? And it's ugly. So people who do a feather margin are used to PFMs, because you know what? That metal could be made knife edge. So feather margins or infinite bevel, or basically prepping a bevel into the sulcus and letting your lab technician find the margin, which is just the most gingival part they can see. That's essentially what the feather margin is. But we can't do that anymore. Why? Because the materials we have to use are dictating clinical changes. What do I mean by that? If you look at this paper, margin design and fracture loads of zirconia crowns, because zirconia is probably one of the most common used materials for all ceramic crowns. Well, chamfer margins give the strongest crowns. So you have to learn how to do a chamfer margin. And these are two Emax crowns, because if this was zirconia, you wouldn't be able to see it. Zirconia is white. It looks like metal. It looks like gold or some kind of metal on an x-ray. But these are Emax crowns I did. I did it in an office with my system. And this is the kind of margin you want. You want a nice emergence out of the tissue, because this is going to be healthy long-term. But how do you prep and what do you prep with? Now, I have some very particular burrs I love. I use a lot of Alpine burrs because, first of all, even the coarse diamond cuts very smooth. And that's really important to me. I don't have a ton of burrs, but I use specific burrs. If you're using a depth cutting, especially for anterior teeth, but you can also use depth cutting in posterior teeth on the buccal or lingual. And I also use for interproximals. I love the Soft Flex ET, stands for extra thin. These are great for interproximal polishings. But depth cutting on the occlusal with a round burr, or there are other burrs for depth cutting occlusal, very, very valuable. So you have enough restorative material and it doesn't crack. This is not gold where it can be minimal. This is a ceramic material that requires. And if you go with the minimums all the time, you're going to have cracks. This is my burr kit I use, and I love the burrs in this, and I'll explain some. It's beyond the scope of this webinar, but I'll explain some why I really love them. And if you're ever drilling on zirconia, Alpine has these Z-Rex zirconia burrs, which if you want a burr to cut zirconia and cut it like a, like an Emax, like a lithium disilicate or something like that, these are the burrs. My oral surgeon once called me, he said, what do you use to cut through zirconia? I go through burrs and burrs and burrs. I said, let me send you some of these Z-Rex burrs, and you let me know what you think. And I sent him a pack, and he called me and he goes, thank God, these things cut beautifully. And they really do. So you really want to check out, if you're doing a lot of zirconia, you really want to check out these Z-Rex zirconia burrs from Alpine. But this is one of my favorite burrs in the world. And why? First of all, it's an extra fine. Typically, when I finish margins, whether it be veneers or something like that, I usually use a fine burr. But fine burrs have to be polished a little bit. It's a fine grit, but it still requires polishing. Not these extra fine. These extra fine cut so nice and smooth that I just have to hit it with a little bit of polish afterwards, and the tissue reacts beautifully to it. So I love these yellow striped extra fine burrs. And you can see I have, if you look at the burr kit I have like 3 or 4 different varieties in it because I just love them. As far as finishing burrs, if you are going to use a carbide finishing burr, only use a safe end one, because if not, you're going to gouge that root and you're going to cause sensitivity, especially if you're finishing the margin. Safe end finishing burrs are really, really important. And what do you use to polish? I use a ceramic polishing kit by Alpine as well. I like their whole things. I like their whole lineup. It's a 3 grit system. I know people go, I only want to use 2, save clinical time. You're not wasting any more clinical time, 3 versus 2. Are you saving 15 seconds? So I suggest get a system that really works and polishes well, because people will be able to tell if it's polished well, and they'll tell you. So these are great burrs for that. But when you're prepping to get enough restorative material, you have to remember you're also prepping in planes. If you just come in with a chamfer burr and put it at a little angle to prep the lingual half of the occlusal and the buccal half, you're not going to really or normally get the proper shape. This is the proactive part. Think, how will the restoration be made? You have to think with the end in mind first and then work your way back. How will this restoration be made? Therefore, how do I prepare it? So I like to use a burr that will give me that contour natively, and these barrel burrs are great for that. They come in different widths and lengths for various occlusal tables, but this is how the restoration will be made. And you can see equal thickness of ceramic, which is very, very important. Now, if you don't, and you prep more like this, again, think, how will that finer restoration be made? It will be made like this. And what is this area? This is your potential fracture line, your potential crack. And it will. It's just a question, because especially on second molars or first molars, we know as people age, their wear and tear on their teeth gets worse. So and not everyone wants to wear a night guard. So be proactive, provide the necessary room for the restorative material. And I don't care if it's zirconia or whatever. Zirconia breaks too. It's not indestructible. Interproximal finishing. because I don't know about anyone out there, but I've nicked the occasional adjacent tooth when I'm preparing a tooth. So I always will polish the interproximals with these soft flex discs. And it just gives you a really nice insertion protocol, meaning if you have jagged contacts, it can really hinder the insertion protocol. So give yourself less headaches and just smooth the interproximals. If you're doing preps that you're saving the interproximal, such as more traditional veneer preps or something like that, always take a diamond strip or disc through them. You're going to create this hair thin, I always say tissue paper-like thickness or reduction, but that will make it easier for the lab to see, easier to scan, easier to take an impression, and easier to insert. Don't just let the lab guess. Give them a clear demarcation because you've gone in and slenderized or basically opened up that contact just that hair. Okay, so what is my protocol for prepping teeth? First, starting with healthy tissue is a must. If you're not starting with healthy tissue, you know you're working uphill the whole way. Okay, so I always try to keep my margins super equigingival. That's the great thing about adhesive dentistry, non-metal adhesive dentistry, is that we can keep our margins super equigingival because the adhesion is really helping retain our restoration. So what do? I evaluate the tissue. If I think there's redundant tissue, I use my laser. I have a diode laser, and I think they're invaluable. I've used diode laser since the mid to late 90s. I've gone through various ones over my career. Invaluable. And most of you probably have it and use it in hygiene because it's very valuable in hygiene as well. Very worth the investment, a diode laser. After that, I typically pack a cord, a 00 or 0 in the sulcus. Why? Because it pushes the tissue away. I don't want to nick the tissue. If I don't have bloody nicked tissue, I can usually get a really good scan and a really good impression. If I have to manage blood, it's a problem. So again, being proactive, protect the tissue. Then after I prep and I create a final margin, I'm then going to see and evaluate further. But what kind of retraction cords? There are a ton of them out there. A lot of them are impregnated, some aren't. I generally used impregnated ones. If I use ones that aren't impregnated, I usually dip them in hemodent. I'm a big fan of aluminum chloride versus ferric sulfate. I think ferric sulfate is messy and it tastes absolutely horrible. Not that any of this stuff tastes good, but I'm a big hemodent fan. And I usually have epi with the cords that I use. Then after that, you want to evaluate for additional retraction. Do you need additional retraction to capture it? If needed, I might pack a 1 cord. And this is one long cord. This is just one long cord that I've tucked in. And then I leave it in. I have the patient bite on some gauze. I leave it in for about 5 minutes, and then I pull it out. Okay, and then I can get my really good impression. If it's marginal, actually it looks pretty good, or maybe there's just a little bit of bleeding because I did nick the tissue, then I use paste retraction, and I love paste retraction. It's quick, it's efficient. There are many different ones out there. The first one ever in dentistry was Expasil. And I've used all the other ones, but I always tend to go back to Expasil because I like the consistency. It has aluminum chloride in it, so it stops the bleeding like that. So try them if you haven't tried them. The more viscous ones are things like Expasil, and the other ones will stop the bleeding. They're just not as good with tissue retraction. But look at the combination. If you have a person like this is a second molar. The old restoration had the margins buried in the gums. I had to do a post. You can see a fiber post placed and a core in there. But look at that tissue. It was so far under the gums, I couldn't believe it. So I lasered it. And of course, it didn't stop bleeding. It was quite inflamed. I then syringed Expasil around it, had them bite on cotton for a few minutes, and I rinsed it. This is what you want to see. A scanner looks at this and goes, thank you. But of course you can get a great impression of this, but this is really, really valuable to be able to do. So if you have a laser and you have putty retraction, you have quartz, you have everything you need to get really good scans and impressions. But especially paste retraction, it's just not for impressions, because here's someone where I was doing upper and lower veneers. We're just in the upper veneer stage of they're wearing their provisionals. As soon as I take off provisionals, trying the restorations, and then we get them ready, the first thing I do is I syringe Expasil around all the preps. The reason why I do that is because it will eliminate, I will have no circular fluid or bleeding or anything when I'm going to, bond this in. So I think, again, being proactive, I'm not waiting for bleeding to take care of it during the bonding process. I'm taking care of it all before. So when do I use impression material? Well, I use it a lot still. And like I said, I've had scanners for over 20 years. So because I think it's very valuable. Now, I have in-office CAD/CAM, like I said, and what I typically do is we go through the whole process digitally. We scan it and we design it and it's sent to the mill, but we snap an impression real quick. And this is the Affinis impression material. The reason why I love the Affinis impression material is because no matter what viscosity you're using, they all flow beautifully. And that's really the key. We take an impression. We will then just put wax around, pour it up in a quick set dye stone, and then we just pull off the wax. So we have basically a laboratory technician's dream, a solid model, so nothing can move contact-wise, and it's ditched. You can't ask a lab technician, this is what they want. Now, after the restoration is made and it's glazed, it is tried on this model, and it has to see beautifully on this, so when it goes to the mouth, it just drops. Now, people say, well, why are you taking an impression, pouring up a model? Why don't you just scan and print it up? Well, here it is. I have printers too. Okay. But why would I waste the time and energy to print this little model when an impression and a quick stone is, number one, more economical and quicker? So, we have all these tools, but use them where appropriate. To me, it would be ridiculous to print up a model like this and do it when I can do the other quicker and cheaper. Okay. But another use I have for printing, though, is because I do my own digital wax ups. This is someone before, and these are printed models, obviously, and this is my diagnostic wax up I did before, and you can see a change in the arch form and all that nice stuff. This was them before, and this was their temps. Now you can see this is when I'm the most critical, and I made a big mistake. I don't know if anyone can see it, but those centrals are way too short, and the necks need to be tapered a lot more. So this is the time I take some pictures, or I'll scan and I'll tell my technician, this is what I need, change it from here, blah, 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 blah. And then I get this back, which is exactly what I wanted. So before, this is the following day after I put in the uppers. And then this is a week later. So I like to design smiles and I like to design my restorations. I have a whole set of teeth I've designed myself that I use in my software. I don't use dental software. I use different software to do my diagnostic wax ups. But it's much easier for me to do this. This is another example. This is a patient who came to me and wanted those 4 teeth replaced. She thought that's all she needed. Well, I did a diagnostic wax up of 10 teeth. And so if you look at her arch form before and you look at her arch form after, you can see the difference. Well, this was before the holidays years ago. This was an older case. Years ago, we were coming to the Christmas holidays, and I said, I don't want you going through the holidays with that horrible bridge up there. She has 2 implants. The laterals aren't there. They are implant teeth, and the 2 centrals are PFMs. Horrible looking. I said, let me at least replace that bridge with a temporary bridge so you can go through the holidays with nice looking teeth. And she's like, oh, you want to do that? I go, yes, please. So I did that. She comes back after the holidays and says, my husband says I have to do more teeth because the front teeth are beautiful and the others aren't. So guess what? We did 10 teeth. So this is the education process. If I didn't have a scanner to be able to scan this quickly, do my own diagnostic wax up, and then do this kind of stuff, this is the stuff that will get the cases. It's the education of being proactive, showing them what they need. They do, and even if they don't agree, they will later tell you and agree with you. So do we have this big rivalry with impressions and scanning? Unfortunately, we do. I don't know why people hate these things. Maybe because they don't know how to do them right and they gag people. I love scanners too. But to me, it's not a versus, it's an and. Impression and scanning. I think to really be on top of your game, you need to be good at both, and you will utilize both in your practice. So I'm coming out. I'm anti-jittle, I always said. And I think you should be too. There are times an impression is easier and quicker, and there are times scanning is going to be easier and quicker. And it really depends. Also think about the fact that if you only have a scanner, you better get printers in your office, and there's more money. So before you invest in equipment, look at the ROI. Buying all this equipment and printing models, to me, is not worth it. There are other cheaper printers you can buy, but if you're going to make appliances that go in the mouth, then you have to stick with the dental printer. So you have to look at your numbers. As far as the impression material, again, I love the Affinis stuff. Their medium body, which is the blue, flows like a light body. That's why I show here, I used it for final impression because it flows like a light body. Their green is their light body, but I love the medium body. If I need to take an implant impression and not a scan body, I love how it flows around the impression analog. So let's talk about, now that we've scanned or taken an impression, let's talk about what we're going to do, and that's adhesively place these restorations. This is adhesion right here. What is this? This is your resin cement or your restorative material, like your composite. This is the hybrid layer everyone talks about, and this is your dentin. So the dentin to hybrid layer is mechanical retention. The hybrid layer to restorative material or cement is a chemical bond. Now, there are many online resources, Reality, CRA, now called CR, Dental Advisor, there's plenty. I've been on the Reality board for about 20 plus years. Yeah. And it's really great because we get to evaluate products that come into the industry, everything from lasers to lights to retraction, everything. So I get to see what's out there, what's coming in. And, you do this long enough and you see products resurfacing that failed and they're kind of putting them under a new name, or maybe they've improved them and they come back. It's very interesting to see how things evolve. But those types of evaluation papers, now everything's online, they're pretty valuable if you're ever questioning what kind of adhesive should I use? What kind of digital camera should I get? What kind of scanner? Those things are great. So let's look at an adhesive flow chart. So we're going to start with the cleaning. We've prepped, we clean. Now, if it's deep, I'm going to cover what I use when it's deep. But let's just talk about how we clean. We're going to rinse and lightly air dry after we use like a chlorhexidine, a Conceptus type cleaner. We're then going to use phosphoric acid, typical etchant. If you're using a total etch system, which is a two-step etch, you etch the enamel first and then you inject and fill the prep. That's the 10-second enamel dentin etch time we need. And then from there, you're going to rinse it out, lightly dry. And normally you're going to use some kind of wetting agent, like a Gluma. You're then going to lightly air dry, and then you're going to apply your adhesive, lightly air dry, and then according to whether you're doing a direct or an indirect, for directs you're going to cure, for indirects you won't cure because the film thickness of these adhesives is usually too high to do that. Now, when we have the newer, well, they're not that new anymore, but universal adhesives, that is a selective etch system, meaning it in the universal is an etchant for the dentin. So you only have to etch the enamel, you rinse it, lightly dry it, and then you apply the adhesive. No wetting agent is necessary at this point. Just don't dry the tooth. Don't make it bone dry. It should be a moist or matte finish. Apply your universal adhesive, air dry, make sure there's no pooling anywhere, And then you cure for both directs and indirects. Okay. Now, this is just a study showing that, yes, for these universal systems, the selective enamel etching is recommended because people say, well, why do I have to etch it all? This is why, because the universals do not etch the enamel quite enough. So just do that separate step of etching the enamel. So when we go back to this, the vast majority of things you're going to use nowadays is a universal adhesive. And I'm a big fan of One Coat 7. There are a lot of other great ones out there, which I'll show some later. But this is a really great universal adhesive to do all your needs. Here's an example of a direct composite. Okay, so isolation, and then we're going to clean it with Conceptus, chlorhexidine, many different varieties. Okay, we do our selective etch, which is the enamel first. Rinse it off, the moist matte finish of the dentin, and then we're going to apply our adhesive. Now, how much do you apply your adhesive? In general, apply 2 coats for about 15 seconds each, and you'll be fine. No matter what brand, that's a good rule of thumb. 2 coats, 15 seconds each. Air drying, I use a dedicated air dryer, not the air water syringe. It's a dedicated pure airline. And then I will cure. 10 to 20 seconds, depending upon your lights. Flowable layer first. Okay. Why do we want a flowable layer first? Well, studies have shown, and we've known this since the 90s, that you have, with a flowable composite first, it really reduces shrinkage, stress, occlusal force problems. That means no sensitivity. So I highly recommend a flowable layer first, a thin flowable layer. Okay. I often then use a high value flowable as the first layer. And why I do that is because anything in depth or thickness, like you will have a composite, will get gray. So I start with something high value to prevent that from happening. I've done that forever in my career. So then my initial resin layer after the flowable, I will cure that. I will then come in with a second layer, the enamel layer, if you want to call it. And I use a lot of different instruments. I use a lot of these. A compo roller especially is one of my favorite. Ivoclar has their Optrasculpt and their other hand instruments, but I really believe these are smoothing off the composite with the enamel surface. These are invaluable. And then I do buccal lingual curing at once, and then occlusal curing. If anything, I'm an over cure for sure. I don't know if there's a program like AA for it, but I'm an over curer. So here it is after, and you can see I did the tooth and back of it the same way. And this is all really nice and good. And these are, you do restorations like this for presentations and for articles. But what do I do on a daily basis? I do this. It's well sealed, well contoured, and that's all you really need to do to give your patient a really high value restoration. Okay. So don't be overwhelmed when you see all this stuff. People are getting paid to make these. And I've done it in the past where, I've done those kind of restorations for ads and stuff. That's not day to day. This is day to day. Okay. So let's talk about the layering again. If this is your restoration, the first thing you want to do is you want to place your flowable. And why? Because your flowable fills all the nooks and crannies of an irregular pulpal floor, which more than likely you will have. From that, and how do I cure it? I cure it in this direction. From that, I'm going to add the dentin layer. And I'll cure it this way. And then I'll add another one, and I'll cure it this way. That's directional curing. Then what I will do, and even sometimes I will come occlusally, and I'll cure it that way. And then I will add the enamel layer. And I'll cure it directionally. And then I'll add this. And I'll cure it this way. Okay? And then I will hit it this. Again, I'm an overcurer. This is how I layer it. What do I use? Well, for the flowable, I typically use a high value, like I said. I use something like, if I use Brilliant Everglow Flowable, I'll use their bleach shade, okay? For the dentin replacement, I'll use a Brilliant Everglow, maybe BL, which is their bleach, depending upon the shade of the tooth, or their A1, B1, or their A2, B2. If you're an Omnichroma person, you're going to probably use Omnichroma blocker here. Now, the last, if I'm using the Brilliant Everglow system, I'll probably use their BL Trans, which is a bleach trans. And then if you're using Omnichroma, you're going to use the Omnichroma. So that's what I would typically recommend if you're layering. Okay. As far as polishing, again, I love these disc or whatever they're called polishers. They are just so efficient at polishing the nooks and crannies of restorations. The only thing they can't really do is the gingival, and that's what the points and the cups are for. But otherwise, the facial, the occlusal, the lingual, these are great, great polishers to use. Now, I talked about deep decay. If you have deep decay, this is where I put some kind of liner. Okay. Which liner do you use? There's all different kinds. Theracal, Ultradent has theirs. There's a 3M. I'm a big fan of the Theracal. That's what you see here. And you also will note there's a cord in the sulcus, okay? There's a cord in the sulcus because I don't like having to finish past my margin and possibly cause sensitivity, okay? You can see selective enamel etch, and then I'm going to apply 1 coat universal. 2 coats, 15 seconds each. Evaporate the solvent, my dedicated air dryer, and curing. And then I'm going to layer a material in there. If it's real deep, you might need 2 different layers of 2 different shades if you really want it to disappear, which I did here. But, you know, I've been fooled because like everyone, when Omnichroma came out, I was a huge Omnichroma user. And when I did this restoration for this patient, I was going through the composite and I just picked the white cap because I know that's Omnichroma. But then when I looked later, I didn't use Omnichroma. I used the BL Trans of Brilliant Everglow. And then I thought to myself, is this stuff just like Omnichroma? So then I did my own test, Omnichroma versus Brilliant Everglow. And I had a little dollop of each, smushed them down, cured them. And you can see Omnichroma is a little more translucent and a little lighter, and you can see the BL Trans, not quite as translucent and a little more color to it. But to get restorations to disappear with Omnichroma, you often have to use the blocker, if not all the time. So think about it, and I looked at this and I went, this is interesting. If you take Omnichroma plus the blocker, you get the BL Trans color, don't you? And so I started using BL Trans in place of Omnichroma and the blocker, and that was the result I got. So it's really amazing. So, and the truth about universals are they're okay, but they don't blend to everything. The Omnichroma system is really just 2 shades. It's the blocker and the Omnichroma. Brilliant Everglow, A1, B1, A2, B2, those are your go-tos. If you have a lighter shade, you're going to need additional shades, or lighter teeth, you're going to need additional shades with both systems. For Omnichroma, you're going to need to use another brand. For Brilliant Everglow, you just use their BL shade. So for me, of the Brilliant Everglow system, these are only the composites I use. Okay, I use the BL for lighter teeth. Otherwise, it's A1s and the A2s, and the BL Trans is my go-to enamel layer to blend and make everything disappear. Here's an example, and I'm not the best direct resin person. I always pride myself on indirect ceramics, but this person wanted all these things closed. And so I just used the A1, B1, nothing else, and closed all those interproximals, those little dark triangles for those patients best as I could. So I just think it blends beautifully. I don't have to use multiple shades layering like you typically would, and the patient was pretty happy. So how are we going to treat when we have these indirect restorations instead of direct? How are we going to treat them? Well, first set yourself up for success. Be proactive, like I said before. You have to start with the end in mind, work your way backwards, because the key for me is, how am I going to insert this? Because based on the insertion protocol, that's going to determine how I prep the tooth and what I do with the prep. If I'm going to adhesively place it versus conventional, can I isolate the area, which means, can I remove the excess cement? To me, that's what it means. Can I appropriately polish the margins? If you can, then go ahead and proceed. If you can't, well, then you got to do it conventionally. And if you do it conventionally, is a buildup necessary for retention? If it is, well, you got to place a buildup. And after that, you proceed. If it's not, you just proceed. So this is what I mean. Start with the end in mind, work your way backwards. It will tell you what to do. Okay. And the key to understanding is the type of material you're going to insert. And they're really, several types now. I never really included resins, but because of the printers now and people are printing resin restorations, I've included them now. But this is nothing new. Indirect resin restorations we did in the 90s. And then we stopped doing them when we got ceramics. But for some reason, they've made a resurgence because people can buy printers now. But if anyone was around in those 90s, Bell Glass was a really popular indirect resin, and it has pretty much the same physical properties as what you're going to get in the printed restorations now. So just look it up. I have a chart that I've shown in other presentations to show that. But glass ceramics, pretty much lithium disilicate is what I'm talking about. Emax is the most popular, Lithipress, and zirconia. Of all these, I would say Emax is my number one go-to. I rarely use zirconia, and I don't use indirect resin restorations anymore. I've done them. I did a ton of them in the day. I don't see the point anymore. That's just me, and you might love them, because I loved them in the day myself. But how are you going to treat the internal surface of these teeth? Well, we look at each category. You're going to sandblast. Now, this is what the lab does if you're using a lab, but if you're doing things in-house, you need to sandblast the restoration. With a glass ceramic like lithium disilicate, you're going to etch it with hydrofluoric acid for 20 to 30 seconds. And zirconia, you're going to sandblast. Now, make sure your lab is doing that. If you're getting everything from the lab, make sure they've already sandblasted your zirconia, or they've already, and most of the labs do this, but double check. You don't want stuff popping off and then they say, oh no, we don't sandblast. We leave that up to you. Most labs will always etch your glass ceramic. Okay. So just double check. So after you insert the restoration, after you try it in, I always assume things will be contaminated. And I think you should too, to avoid the hassles. So I've tried in this resin restoration. I've tried in this Emax restoration. I've tried in this zirconia. Now what do I do? Well, you want to clean it. Well, again, this is assuming it's already been either sandblasted or the glass ceramic has been treated with the hydrofluoric acid. The cleaner. I used to break it down to different cleaners, but here's the simple truth. Use a zirconia cleaner for all your indirect resin restorations. And I'll show you why. I'll show you a chart that shows you it's the best, it's the easiest, and I'm a big firm believer in streamlining your product. So use a zirconia cleaner. There's many of them. Here's 3 of them right here. Then you need a coupling agent. Silanating agent, very commonly referred to because they enhance adhesion. Well, for resin, use a silane. Monobond Plus, Clearfill, there's tons of different silanes out there. Glass ceramic, same type of thing. You're going to use a Monobond Plus, a Clearfill, you got tons. Now for zirconia, you need a zirconia primer. Why? Because zirconia primers have something called MDP, or officially 10 MDP. And I wish I could say the name, but I don't want to butcher it. But that's the ingredient in a primer that will enhance the bond to zirconia. Now, if you notice, you see some redundancy in the products because there's something called a universal primer. And Monobond Plus, Clearfill are the only ones that I know of that are silanating agents with MDP. And so if you want to streamline your protocol, just get one of these and it's good for all the restorations you're going to use. As a quick note, what do you do after you've applied your universal primer? to your restoration. I typically leave it on probably less than 30 seconds. I dry it. I know some people say a minute, but I also saw a study that showed leaving it on for 5 seconds and drying it, leaving it on for a minute and drying it, you get the same bond result. So I leave it on for about 30 seconds. We dry it. Question is, do you apply your adhesive to your restoration? Again, a study came out, I think it was in the 90s, by Michael Miller of Reality, saying there's a sufficient wetting agent in your resin cement that you don't need to apply an adhesive to the intaglio surface of your restoration. And you're not going to do that with zirconia, but I'm talking particularly glass ceramic or resin. So why not just etch zirconia? Because it shows it's not going to give you a better bond. You need to use an air abrasion system. As far as zirconia, when you try it in, assume it's contaminated with the saliva, the phosphate lipids in particular. Okay. And here's the thing about the cleansing. If you want to see a research paper about, consider your zirconia, if it's exposed, you need to clean it. Okay. And then here's the thing about the 10 MDP or MDP. This is what you need in your primer to enhance the bond, the chemical bond to your resin cement. Don't use the silane on zirconia. Why? Because strict silanes are meant for glass ceramics. Again, we have the universal primers, so everything changes. Just be careful what you're using. Use a universal primer and avoid the headache of worrying about it, really. And here's a study. I want to thank Dr. Nunez from Bisco. He supplied this to me years ago, which I think is great. And it talks about if you get this restoration from the lab, say, there's no contamination, no cleaning, you put it in, this is your bond strength of zirconia, Emax, and they did stainless steel for some reason. But let's just look at zirconia and Emax. Now, if you tried it in and it's contaminated with saliva or something, and you just clean it with your air water syringe and dry it, and then go through the process, these are your bond strengths. And this is why you hear zirconia popping off, because I don't think people understand it really needs to be cleaned well. Now, if it's contaminated and uses zirconia cleaner like Zirclean, which is the one I use pretty much, look at this. You get better bond strengths. And you get better bond strengths from Emax. And stainless steel I don't worry about because I don't do stainless steel. So that's why I'm saying use the zirconia cleaner for your Emax, for your zirconia, for your resin, because it's going to give you a better result. It's just easier. Okay. But a huge difference between cleaning and not cleaning. So you definitely want to clean these restorations. Assume they're contaminated and you'll avoid headaches. So again, here it is. Get yourself a zirconia cleaner, get yourself a universal primer, and call it a day. Now, how do you make your life easier? Well, you make it easier with isolation. There's tons of different retracting devices you can use, okay? Use them. It makes it easier, your dentistry more predictable. The most predictable would be isolation with a rubber dam. I don't always use a rubber dam. I always use some kind of isolation. I don't always use a rubber dam, but it is kind of, to me, the gold standard. And sometimes I can't invert the dam by the prep, so I use a little extra retraction with a rubber dam like this. As far as how I insert veneers, a lot of times I use a total etch system where I don't cure the adhesive, but when I do use a universal system, it's basically the same protocol. I'll clean, I'll etch the enamel, total etch, I'm going to etch the dentin too. But here I'm just etching the enamel and I'm rinsing it off. I'm applying my adhesive, and now I'm very careful to remove all the excess with a dry brush, air dry it. If I see any waves of adhesion or of the adhesive, I will then get a dry brush and remove it, if not air dry it off the tooth. That's the key, because when you cure it and then you can't seat your restorations because you had a pooling somewhere and you just don't want that hassle. If you're concerned about it, then use a total etch system that you don't cure and everything kind of goes in at once, okay? I'll then have the veneer, as I hold it, filled with the resin cement, and I will put in 2 at a time, clean the excess, and I tack cure with a 4mm tip aimed at the apex. So I rest it on the margin mid-buckle, and I aim it at the apex to only cure that. After that, and I put them all in like that, two at a time. I usually do the two centrals, and then I'll do one side and then the other, two at a time. Then I go in and I floss, and I go underneath the gums and I remove. And as I do each interproximal, I cure it. And I do this interproximal, and I'll cure it. And I'll do this interproximal, I'll cure it. Why do I do it that way? Because if you just floss them all and then cure, you'll get bleeding in these areas, and that's not good. So you want to cure as you clean. Like this. See the bleeding interproximal? I don't worry about it too much. Why? Because it's already cured interproximally. I always hit it with two lights. These are the Velo lights from Ultradent. I hit buccal and lingual two at a time. Posterior indirects, I'm sorry. This is what you saw before. If there's anything deep, I will use some kind of liner. This is a very old case. This is probably from about 2008. I did them in the office using Emax, and here's the final result. This is right after removal. You can see the redness from the rubber dam. So adhesives. Well, we have an etch and rinse, like I talked about. That's the total etch. And then we have the universal. Now, we did have self-etch. People go, what about self-etch? Self-etch have been rolled into universal, pretty much. So you don't want to worry about self-etch. It's universal or your total etch systems. These are your top, I shouldn't say top, there are tons of them. You know, when I first started adhesion, I think there were like 2 or 3 total etch systems. Now there's probably over 100. So use which one you think it works in your hands. They're all really good. It's just what works for you. As far as universals, these are really good ones. Of course, I was showing you one coat universal. All Bond has Bisco has theirs as well. And resin cements, light cure only. Like this is an upper and lower, actually full mouth case. I used all light cure materials because, first of all, I love working time and I can cure through all these restorations, which were all just Emax. But these are some great cements. Really, a resin cement, I would say don't worry about the resin cement, but worry about the viscosity, because preference comes from the viscosity. Some people like really runny cements. Some people like more viscous. What do you like? Because each cement's a little different. I personally prefer a little more viscous cement to hold the restoration in place versus a little watery, because then it gets all over the place. But that's just my preference. Now, let's talk about when you insert a crown and it's a retentive crown. You can use a dual cure self-adhesive cement. Now, what's a dual cure self-adhesive cement? It doesn't have a primer. It's basically, you hook on one of those tips and you syringe it out and you inject in the crown, you put it in. So your technique would be sandblast the prep if needed, which a lot of times is a very valuable thing to do. And then you clean it with chlorhexidine. Make sure the internal surface of the restoration you're placing is properly treated. Inject the cement into the crown, tack cure it, and remove your excess. Okay, and then do a final cure. Pretty straightforward process to do. Okay, and if you're talking about which are some of the ones most popular, these are all them. You know, you have your 3Ms, your Biscos, you have your Kerrs, and then Solo Sem by Colty, which I think is really top-notch dual cure self-adhesive cement. Okay. Now, if you have questionable retention, well, that's when you want to use a dual cure SEP, which stands for self-etching primer. Basically, it is a dual cure cement with a primer with it. You have a bottle system with it. So that's where you get the extra retention. And for the most part, this is what you should use regardless, to not worry about anything coming off. It's really that simple. So again, sandblast if needed. Clean the prep with chlorhexidine. Make sure your restoration is properly treated. Apply your adhesive to the tooth and cure if indicated, which they almost always are, but be careful of pooling, okay? Then inject the cement into the crown and seat it. Spot cure it 1 to 2 seconds, and then you can peel off the excess, clean the interproximals, all that kind of stuff, and final cure. Some people will put a glycerin gel around the margins and then cure it. I always tend to leave a little bit and like to finish it down, but do whatever works for you. Now, there are different ones on the market, but notice they all have a bottle with the syringe of the cement, right? You have your bottle, and then you have your syringe of cement. That's the difference between the two systems. The one thing I like is, because I use SoloSem, is all I have to do is add one coat universal, and I have two different systems. I have the dual cure self-adhesive cement in the SoloSem, and then if I add one coat universal, I have the dual cure self-etching primer. So again, inventory simple this way. And really, a note about the inventory, there are many, many high quality adhesives, cements, composites, etc. to choose from. And just because you didn't see yours here does not mean you're using an inferior material by far. Okay. And so to put it simply, have a limited inventory, be smart, not impulsive, because the ads are great, aren't they? Be smart. And keep things refrigerated when possible. That will extend the life of them and the efficacy. I always keep things refrigerated overnight, over the weekends, everything. Don't worry, keep it refrigerated. So in closing, I want to thank you all for staying. And I want to definitely thank the people that make this possible, Viva Learning, Colteen, and most of all, you for staying here and listening to me ramble on. So we can go to a Q&A, and this is my private email. If you want to ask me something and it doesn't get answered here, please email me, chrisdmd@aol.com, and I will answer. Just make sure you put something bold in the subject matter so I see it, because sometimes it just goes to junk and I don't see things. Q&A. All right. When would you polish in approximately is one question. All the time. I use composite polishing strips in approximately. I use a lot of cosmetic polishing strips, but I like to polish in approximately all the time. Again, when I'm putting in a restoration, I usually also put a cord in there so I prevent anything from going past the margin, but always like a polishing strip. Someone says I've been using IvoClean zirconia cleaner, but recently read a study that 5% sodium hydrochloride is effective, is not better, is a fraction of the cost. Any comments? No, I don't know about that. One study shows it, okay, but where are you going to get your sodium hypochloride? Is it consistent? I'm sure there are cheaper options. I don't know much about that though. So what luting material for zirconia? I use the same materials, whether it's zirconia, Emax, all that stuff. I'll use SoloSem, but I'll use one coat universal on the prep, cure it, and inject the SoloSem into the zirconia where I use Emax and seed it. So that's the luting. I mostly stick with a dual cure self-adhesive primer system, because why worry about things coming off? The dual cure the dual cure self-adhesive cements are fine, but you better have great retention or it will come off, because studies have shown that bond strength goes down drastically over time. That's why I don't just use those. Can we use electrosurge? Yes, actually, you can absolutely use electrosurge. I jumped from electrosurge because I stunk at it, really. And electrosurge is fine. If you're good with electrosurge, God bless, go for it. Thank you, Dr. W. I joined late. Can you talk about your choice for access fill after endo? That's great. If an access opening of an endo? Okay, if it's a tooth, I typically inject a core buildup material into it and then cover the top surface with a really good composite, like a Brilliant Everglow A1B1. If it is a ceramic crown, that they've gone through. I will treat this opening in the ceramic crown. I will etch it with hydrofluoric acid. I will silanate it so I get a bond to the ceramic part as well, so there's no staining and it looks good.
5 p.m.
Oh, do you air thin before applying your bond twice? No, I don't. Thank you. So when I'm applying 2 coats of an adhesive, no, I do not air thin between 2 coats. So 1 coat, 15 seconds, I'll dab my brush again, another 15 seconds, and then I will do the air drying. Invisalign attachments on crowns. How will you do? Invisalign attachments on crowns. I don't do them, but you're just going to bond to them. You're bonding composite. So you on crowns, you micro etch. Use your micro etcher is the best thing to do. Then put silane on the if it's a Emax crown, and then go through your adhesive process. Do you prefer polishing strip over the disc when polishing? Strip. I much prefer a strip over the disc when polishing it approximately. Lower incisors especially. Yeah. Just be careful you don't cut the tissue. Do you use gold, and how would you cement gold in direct? No, I don't use gold anymore. I haven't used gold in so long. But if I was cementing gold, I'd probably use the dual cure self-etching system like a solo step. So on the prep, I would put 1 coat universal, air dry it, cure it, and then I would use solo sem. But I would also micro etch the gold. And also, this is a good question because it brings up the Monobond Plus is a good metal primer as well because of the MDP in it. So use that on the metal after you micro etch it. After placing a screw between implant crown and covering the screw with a small con, do you suggest cement or just filling composite? Actually, for an implant, I actually put plumber's tape in there, and then I put composite, usually something a little more opacious, and then a final layer on top. And I usually treat the top of the implant crown. I usually do Emax on the top of my implants, so I treat the ceramic so I can bond to it. But does it make a large difference? I don't think so. The Velo lights say cure for 3 to 5 seconds. Yeah, everything is about curing. So one question is, the Velo curing lights say cure for 3 to 5 seconds. Do we still need to cure for 10 to 15? Everything is about quick curing nowadays, and everything's about bulk filling. Do things right, and you don't have to do them twice. And so under curing, I think, is a big problem. I know the Velo lights are strong. I've used them since they've come out. But I still cure 10 to 15 seconds, and I just don't have issues. If you're not having issues with 3 to 5, keep doing it. But I just err on the side of more, and I don't have headaches. One last question. What's the name of the universal bonding you use? You know, Onisem or something. The universal bonding system I use is 1 coat universal. That's the one from Colteen. I think that was it.